About metformin. Metformin, of course, is the favorite drug of most family physicians and most endocrinologists. Can we start metformin both the lean patient and the obese patient, or should we only use it for the obese?
Yeah, I think at times we have very lean people in our country, who come to you with diabetes. Their BMI is below 19. Now, those people I would not give metformin because it is an anorectic drug, basically a catabolic drug. See, I want to create an anabolism in those people and make them a little stronger, add some muscle mass. You see, so I would not like to use there. There, I think the drug of choice would be different, But all obese people, yes, metformin is definitely the drug of choice.
Okay. By the same token, between 19 and 25 BMI, normal weight, neither lean nor obese, would metformin be our first choice?
I would use a small dose of metformin.
Smaller dose.
Never go above 1000 milligram in them, and even anybody else 1500 milligram a day. So I would use that, but not push a large dose of metformin there.
What is the maximum dose of metformin that we should use? I have seen 850 TDS. Is that a good dose?
Yeah, that is a strict dose. I would say 500 TDS is about the maximum you can use without much side effects. So I would stick to about 1500 in most patients. I would do that, yeah.
And between short-acting and sustained release?
Sustained release has advantages. It has never been brought out very well in the literature, but there are definite data that the blood levels you attain are a little better, and the side effects you have of GI side effects with metformin, like a little bit nausea, anorexia, metallic taste in mouth, occasionally diarrhea, those are minimized with the use of sustained release drugs. But it has never been brought out in the literature very well for the reason that sustained release are very expensive in other countries. And most of the research, even if it is done in a country like ours, is never highlighted. So that as the America has not seen something which does not exist. This is the American way of looking at things. You see, they have to discover. Everything new has to be discovered like that. If you have discovered, it's not valid. So, they have not really carefully seen it. When I ask them, why don't you use such a thing? It's very expensive, there's no difference. They give me such a blunt answer. They've never seen it properly. So I think they like to know the knowledge there. And I would use definitely sustained release as much as possible. In our country, the cost is not much. A tribute to drug industry, the way they've gone around, giving us drugs, very good molecules at a very low cost. It's amazing, yes.
Since you spoke about America, my next question for them will be about Americans. If an NRI comes to India from America and tells you that I have gone out of stock of my anti-diabetic drug, glyburide, what will you replace it with here? Glycinase, that's glipizide. Any other answer here? Deovil is the correct answer. Glyburide is the American name for glibenclamide, which we use as Deovil here. And just as paracetamol there is called acetaminophen. Glyburide is a different name. For you, if an NRI comes with his glucometer from there and tells you that his level is 10 millimoles per liter today, fasting, what is his level in milligrams per second? You don't know. 10 millimoles. Multiplied by 18, 180 is the correct answer. So 5 points there to you. Sir, your take on choice between various sulfonylurea drugs. What is the advantage of glibenclamide over glimepiride or glycoside or glipizide? These are the 4 drugs that we commonly use.
Yeah. We look at the sulfonylureas from 2 or 3 different angles. One is, of course, the efficacy, cost. Apart from that, the scientific criteria are, the possibility of hypoglycemia. And secondly, a very theoretical but may have some physical correlation effect is on what they call the ischemic myocardial preconditioning effect. So the older sulfonylurea like glybenclamide and glipizide are known to occupy the same site on the receptors in the beta cell as well as the coronary vasodilating mechanism is same. So therefore the possibility of impairing the ischemic preconditioning of the myocardium by them. There are some clinical correlates of that because there were studies showing that probably the myocardial damage with the occlusion of the coronary vessel, at least experimentally, is more in a sulfonylurea treated animal where the old molecule is used. And there are arrhythmias which are more when these people suffer occlusion. So I would now, considering from these, the glymentylamide and glipizide is slowly losing their importance. But still, glymentylamide is the most intense stimulation to beta cells. So if you have a difficult patient, it is the right molecule, it is the most inexpensive drug. Other way around, I think you would try to avoid, if there is a possibility of hypoglycemia, you will go to glimepiride better. It's a smooth effect. See? So glymentylamide hits you like country liquor, glimepiride is like a mature scotch whiskey. But you see, so I think there is a difference there. And of course, we have the non-sulfonylurea secretagogues like ripaglinide, methaglinide. The beauty of those drugs are very short-acting. So whenever we treat a patient in a hospital situation and we find that intensified insulin therapy is not producing the desired results, then for sensitizing effect, we use the short-acting drugs. Because in a sick person, you can't use any long-acting drug because once you administer, you don't know how to reverse it. So I think there is a role of those drugs. So I think there are distinct places where you use these drugs, but overall, one should go to the newer sulfonylureas like glimepiride and the short-acting drugs like ripaglinide, methaglinide. And in your indigenous situation, patients can't afford glymentylamide, glipizide is the most inexpensive drug, very effective drugs. Now there has been an objection raised that these drugs, which are the older ones, stimulate beta cells very intensely, sometimes not necessarily in a glucose-dependent manner. Even if blood glucose is low, the stimulation continues. That's how they produce bad hypoglycemia. Therefore, they may exhaust beta cells. So, preserving beta cells is a great slogan. It's as great slogan as Gary Hadar in politics. Preserve beta cell. You preserve beta cell, you preserve patient, and you preserve yourself. So it is a good motto, but whether you can truly do that by using the newer mode of therapy is based upon some in vitro experimental data, short-term clinical studies. Nobody has shown in the long term that this really is true. So I think this remains to be seen.